Everyone hear me? Yeah? Okay, thanks, Jerbil. Just following Lynn is really difficult. She's made me feel very redundant, which is a familiar feeling to most community workers. It's a real danger. Um, so just to let you know that I get very nervous when I do public speaking, and it makes me bumble, and sometimes I lose my train of thought. So if you witness me trailing off and looking somewhat like a monkey, looking for a nut in a bottle, looking very confused, then you know that's happened. So just, smile and be kind. Okay. So I'm going to tell you a little bit about a very small scale study that I did as part of a master's degree last year. I was working with the Community Health Network. I've been a member of the Community Health Network. I'll tell you about that. A lot of the background and the rationale around social prescribing has been brilliantly described by Lynn, and my presentation is very plain in appearance. I have no poems or songs or pictures, so that will make me go faster. It will cut down on the likelihood of Mr. Bean moments. So this is how I like to do things. So the title of the study was an exploration of the practice of attitudes to social prescribing. So the one thing that strikes me when we're talking to community workers and healthcare practitioners is that there are differences in approaches, obviously, and this is what we're trying to bridge. But the chief emotion behind the work we do, it's not we don't want people to stop smoking, go to the doctor less, we want people to lose weight. It's really the crux of it is that life for most people is a continuous struggle, not for biological survival, but for the place in the sun. So it's for people to enjoy life, for people to have a purpose. That's Thomas Saz. I forgot to put the date on 1960. It's so even that far back, though. Has the microphone gone off? Did I do something? No, here we go. There we go. So I'm glad I warned you about this. So it's not just about an absence of illness or an absence of disease. It's about comfort and joy in living. And I think that's what we instinctively know about people who work in what they call the helping professions. Sometimes we're more helpful than others, sometimes we're not helpful. But I think that is the motivation. That's why a young person wants to work in any profession that helps people. So the research partner was the Waterford Community Health Network, which is a bit of a ragtag band of community workers in Waterford City who are focused on health inequalities. So most of us would have worked over the years on projects that looked at the impact of poverty on health, and that would be where we're coming from. So the membership would be from community development projects, of which sadly there are much fewer in recent times, family resource centres, health promotion, HSE are very active in this group, and other community-based health initiatives. So that's the perspective that we're coming from. So what do members of the Community Health Network have to offer? So what is there for GPs and primary care team members and even hospital staff, any healthcare professional? Family support programs, counselling, parenting programs, play therapy, community-based childcare services, community-based education and training, which quite often start people off, including me. About 20 odd years ago, I started with a community education course, which was a lot more, inviting to me than going into a large educational institution when I didn't have that background or experience. A range of issue-based support groups, for example, Al-Anon and AA and Gamblers Anonymous and all of those kind of groups, groups for parents of children who have disabilities. There are single-issue groups there that are available for people to link into. Advice, advocacy, and information. That could be something like money advice, citizens advice. It could also be around political advocacy in terms of, one example I'm familiar with is traveller housing, is that there's a huge amount of advocacy that goes into that work, as some of my colleagues are here today who do that work tirelessly. Health promotion programs, activities to combat social isolation. I know there's a befriending project in St. Bridget's in town, which helps older people make social connections. And then there's horticulture and green therapy programs, particularly I want to mention Ballybeg horticulture program that does a lot of work with a program called the WAVE program for people suffering from mental health issues. So that's not even an exhaustive list. There's so much more. And there are so many more other organisations that even we're not linked with. So I could stand here all day and list what's happening in Waterford. But what we don't do is, I think it's important to say this, because when we're talking to people in primary care teams and who are in medical practice, is that they're always worried about, are we going to lead people down the wrong path, you know? So what we don't do is we do never encourage anyone to disregard a health practitioner's advice. We don't give advice on alternative remedies, and we don't advise or promote private practitioners, and we don't signpost to political or religious groups, and we don't perpetuate unproven health advice originating from social media or internet sites, because I do believe that 2 handfuls of cashew nuts are now the cure for chronic depression. So we steer clear of any of that, and we'd like to make it clear that we do that so there's no question. Just in regards of maybe when we look at some of the things that came out of the research, that would be trust is very important, I think, when you're bringing 2 sectors together. So as well, along that theme of trust, there safeguarding for people who are referred to organisations in the community is quite stringent. So we do care about the quality and accountability, transparency of projects that primary care patients are referred to. So we would think that projects suitable to engage with primary care team patients, we're already endorsed by one funder or another. We're funded by at least one or more state agencies, and we comply with a wide range of reporting and quality and performance systems. So we're already there, we're already screened, we're already working in the way that we're supposed to work. So that's just something that I think is important to say. So some of the safeguarding mechanisms are voluntary boards of management operating under the WHEEL Code of Governance, the Charities Regulator, Companies Registration Office, Children First Guard Vetting Act, service level agreements, KPI logic modelling, and other reporting systems, and external agencies and independent evaluations. And that's just before lunch. So what sparked our interest in social prescribing? We thought there was a large gap between the medical and the community sectors. Now, I'm not here to talk about the project I work with exclusively. I'm here talking about a wider range of initiatives, but in my particular experience, we were working on a traveller health project. We had 4 or 5 traveller community health workers who had the knowledge about their communities and were excellent at linking people from the travelling community with the initiatives that we were running. And after about 7 years, we didn't ever have had a doctor sending anyone to us, even though we had a cycle of delivering leaflets. Now, I have to say there's a caveat here, because this is before we met Susan Murphy, primary care lead, who you're going to meet later. So she's been extremely proactive in remedying this gap, but still, as you'll see, it's not a formal arrangement. So we saw a huge gap in that all of these initiatives and activities were being provided and being funded by state organisations to improve people's health, but the GPs and primary care team members, they didn't know or they didn't want to know. So we wanted to find out what was the case. Oops, hang on, I think I've gone. Okay. Oh, I see what's happened here. My 16-year-old son told me that my presentation was dry AF. And yeah, they do that. So he put some swag on it, and so I thought I'd removed it all, but there it is. Yeah. Thank you very much. Yeah. Thanks, Sean. And just be grateful that there's not a grime backing track. That's all I can say. So this might happen again. So also sparking our interest and, we were becoming aware that there was research. I won't go too much into each one. And Lynn has outlined a lot of the thinking that leads to social prescribing. But the research outlining links between poverty, discrimination, and poor health were these particular writers. Wyatt et al. Is one of I found it the most interesting. What they did, just very briefly, and I won't do it justice, they looked at a group of African Americans in the United States, and their cardiovascular health was, their cardiovascular events were the highest that they'd seen. So what they did was they compared them with non-African American people with similar poverty indicators. So people who lived in the same circumstances but weren't African American. And then they thought that maybe there's a genetic link. So they looked at people and they traced some of their ancestry back to Nigeria, and they went and they tested people with similar gene profiles in Nigeria, and their cardiovascular health was better than this group. So the findings were that it was being black as well as all of the poverty indicators, but there was an extra layer of being black in the States, that they were experiencing reactivity and guardedness on a psychological level, on really from birth, on a daily level, and that they were then, their cardiovascular profiles, they were embodying this experience. So that for me I was very stunned by that, and I did see some, obviously I don't know the cardiovascular profiles of all travel, but we do know from the Irish Traveller Health Study that cardiovascular events and morbidity, mortality in the travelling community are much, much higher than the settled community. So for me, I made a mental link between those two studies. Cohen et al., Little and Guiney, really interesting. They did a study on living in a cold and damp environment in Scotland, and it was people who had fuel poverty and badly constructed homes, and it was really, they linked it to depression, cardiovascular disorders, and a whole range of health problems. And what was fascinating there was they were saying that being cold and only being able to heat a small part of your home has a psychological and physical effect on you, that your life becomes so much smaller when you won't even go into the kitchen because it's too cold, when you're all sat round the one fire, that it, some people might think that's cozy, but when you're too cold to go make a cup of tea, or too cold to go maybe read a book or study in another room, then that has a huge effect on people's. I said I wouldn't say huge, and I keep saying huge because I think Donald Trump has ruined the word huge for me. And I say it a lot, and I'm trying not to say it, but that has a marked effect on people's. Spot the Deliberate Mistake, Wilkinson, 1997, I think, and the All Island Traveller Health Study. So these are all things that were coming, and the Spirit Level as well. A lot of people know Wilkinson, Richard Wilkinson, from the Spirit Level. So that was, we were starting to understand all of this, and you would see it in your own work, but then we were starting to understand these. There also there's a creeping perception that there's an increasing medicalization of the population, and that might just be for old kind of left-wing people like me, but there is evidence, there is a lot of thinking to support this, and only last year the two top studies are linked, Chisholm and the World Bank. So Chisholm was the supporting paper that was given to the Lancet, and the World Bank wrote a kind of a policy paper called Coming Out of the Shadows, or Emerging from the Shadows, and Chisholm's was scaling up treatment for depression and anxiety. And really the upshot of that was that worldwide, the World Bank wants to support an investment of $147 billion. I know I sound like Dr. Evil when I said that, but so $147 billion into treatment of anxiety and depression worldwide. And some of the language used in that paper is about tapping into markets. And they was telling Lynn earlier, they have a little vignette of an Indian housewife who was feeling depressed. And they named a lot of external influences as for her depression, and then said that she had a short course of online CBT and some antidepressants, and then she felt so much better. And this is the World Bank saying, if we put in $147 billion of investment into treating anxiety and depression, we'll get back $310 billion in increased profitability. So it's the economic unit approach to mental health, which I don't fully trust myself. Brandling and House. Barry is an Irish writer who writes a lot on the pharmaceutical, public pharmaceutical prescriptions and levels of economic activity around that. O'Donovan, who was she was my supervisor for the research, so she's written on power and pharmacy around people's lives. And then John Busfield as well has written on pills, power, and pharmaceuticals. So I think that you can't get away from the fact that there is some thinking that it's possible that people will be over-medicalized for things that are from external influences. So who says social prescribing is effective? And Lynn has covered a lot of this. Brandling and House, Poppe et al., Public Health England are a very big supporter of social prescribing. The World Health Organization, even though they supported the World Bank, Stickley and Hugh and Grant et al., they've all done evaluations. And as I say, there's no definitive evaluation of social prescribing, but there's a lot of evaluations out there that show that it benefited the people who took part. So the qualitative research, it's not a feasibility study, small scale, or not a feasible study, sometimes I say, but small scale exploration, and it's the start of a conversation about how linking the medical. Oh no, here's another one, sorry. And we have twirling, yes. So the interviews and focus groups were with community workers, GPs, a psychotherapist, and senior HSE manager, pediatric nurse. Okay, sorry, I obviously didn't wipe these animations off. There's another bounce. So the research questions for semi-structured interviews were, what is your awareness of social prescribing? Do you think it's beneficial for the patient? Do you practice social prescribing informally? And do you think it would be feasible to formalize it? And if so, what would help this? And what are the barriers? And summarize findings. So most of the healthcare professionals hadn't heard of it. And I have a couple of quotes here. Didn't know there was a term for it. But then when we worked through the explanation, people said I would always be looking for what else is going on in that person's life. Sent people to Citizens Advice, Mothers Till a Leis, and one GP said, I think it is happening, but it's very ad hoc. So all of the healthcare professionals felt really positive. Excuse me, I'm just going to take a drink. Some of the quotes, they'd really like to do it, want to roll it out, it needs to be formalized. Excuse me, I think it would be an excellent idea. It could be something hugely beneficial. So it was across the board received very positively. And then I realized that the healthcare professionals did value the informal approach of the community sector, saying, sometimes things are too rigid. They'd be looking to send people into services that are comfortable and more relaxed and maybe more human. So overregulation can cripple a system. And support without formal investigation. They see parents who are great, but there may be some gaps and they might need support. So where could they send people that they could get that support? That's not that doesn't seem punitive or that they've done something wrong. And they valued patients' involvement in the community, so they really got that, psychological well-being, meeting with people, being supported. And from an economic point of view as well, it'll save the HSE money if people are empowered to look after themselves. And what's missing in the community, childhood obesity, prevention programs, and information on diet. So there are some of the ideas that came up. They all expressed opinions on the limitations of the medical model. So I met people who were frustrated with their own practice. They were frustrated only seeing people for 5 minutes when they knew there was a whole range of factors that were going to impact on that patient. So you'd love to have the time, and you don't have time to eat. That was actually true, because the GP I was speaking to there was eating digestives for lunch while she was talking to me. So you could really visibly see that the person was so stuck for time, that really they have to look after people with the worst health problems. We're not going to have time to sit with people for 5 minutes more. It's all crisis. They don't have enough information on the services in the community. It's ad hoc. We don't hear about it. We don't get the information. It's like looking for a needle in a haystack. So they all knew the impact of psychosocial factors and health promotion and education on health. Mental health is deteriorating in society because of the shift of wealth to the already very wealthy. Society is suffering. That's my kind of GP. He was very good. So mental health has come to the fore. People are experiencing severe marginalization and disadvantage. You see it all the time. Support is a huge thing. So they get it. I wasn't sure going in there what I would hear, but they get it. They really do understand. So when we talked about models, the healthcare professionals liked the idea of a database. They liked the idea of a database because it's quick and it's something that they can feel that they can do for the patient, is to say, oh, you're feeling ice, right, we'll go here, I'm going to click a button. And it is good, and that would be a great way, I think, to get the information to the healthcare professionals, because they can't be expected to study everything and understand where everything is and who does what. An icon on a desktop, so, if there's phone numbers floating around, we lose them. But all of the community workers I spoke to, and one of the healthcare professionals, preferred the idea of a hub, which is the link person or a community referrer. So to direct them towards someone, you'll understand somebody's culture. It's that initial connection with somebody. And there's a quote I really love here: nothing will take the place of another human being who can actually sit with you and mirror back what's happening in your life. And you can't computerize that. So I think that's lovely. Compromise is possible. So one quote was, it's not either or. If they have a person or a database, we'd probably need both. So I think that the dual approach is definitely the way to go here in Waterford. So possible ways forward for social prescribing. I hope I got that in my last 5 minutes. So these are the things. We'd have to be low cost, because the network is not funded as an individual entity. So we're a collective. So it'd have to be something that is doable and low cost to start with. So if we develop a prototype database of community groups for primary care teams and hospital staff, that would be fairly low cost start. We could devise and pilot a hub model, including a promotion strategy. That might be as simple as one person in the network being the telephone number that can be called for an initial pilot, short-scale pilot program. That we continue to expand the local conversation with all stakeholders. That's hopefully what we're doing today. And also possibly we could design and promote a social prescribing module for healthcare professionals, maybe to help people understand what the practice is, and also some of those issues around trust and safety that I went over as well. That might be useful as well. I think that is my last slide. So thank you very much for listening.